Factors that I consider when selecting ibrutinib for a patient largely be focused on the potential side effects or toxicities of ibrutinib. Patients that are at high risk for bleeding, perhaps due to prior bleeding events or thrombocytopenia or the need to be on anticoagulant medications are considerations. Cardiovascular history or history of atrial fibrillation is also a consideration. It is noted that there is a track record, and a published track record, of treating patients with these factors safely with ibrutinib. But I do suppose if there are other treatment options, it is a consideration. Part of the main factor with ibrutinib is that patients should understand that it's a drug that is meant to be continued in the long term. It is not that they are trapped on the drug, but it is with the knowledge that the drug is effective so long as it's taken, and that disease does tend to relapse fairly soon after it's stopped. And so perhaps patients that are more inclined for a shorter treatment duration would be less appropriate for ibrutinib. Dose-dense rituximab is an active agent for patients with CLL, but with the development of novel targeted agents like ibrutinib and idelalisib and venetoclax, I do think it is not something that I tend to turn to first. Specifically, some of the main trials were designed as a direct comparison against rituximab, such as the idelalisib plus rituximab versus rituximab alone trial. That said, there are patients that perhaps do not have good access to oral therapies, or in my mind, patients that have autoimmune complications such as ITP or autoimmune hemolysis as the main manifestation of CLL are appropriate for rituximab as a treatment option. At the very least, it can be something that stabilizes disease or kind of bridges a gap to receiving other therapy. Idelalisib and rituximab was shown to be superior to rituximab alone as far as efficacy and progression-free survival and overall survival. Certainly it is an active regimen. There are some side effects that have limited its use, including colitis and other inflammatory complications. I do think patients that are starting this should be carefully counseled about those risks and reminded to alert their physicians and their teams of any new side effects. It is a drug, though, that is active and should not be and should be presented to patients as a treatment option, particularly those that may be having problems or contraindications to use other drugs. At the most recent ASH meeting, a late-breaking abstract showed the efficacy of venetoclax in combination to be superior to bendamustine and rituximab in the relapsed refractory setting. Similarly, previous studies have shown the efficacy of single-agent venetoclax in patients with deletion 17p, which is its current FDA-approved label. Based on that, venetoclax is a very good option for patients, especially those with 17p deletion. Some factors that are important to consider for patients, though, are the need for close monitoring for tumor lysis syndrome. For that reason, perhaps it's not the optimal option for patients that live far from their laboratories or patients with compromised renal function. However, I do think patients are drawn to this regimen, particularly the combination with rituximab, because it's designed to be a regimen that is of a defined treatment duration and is expected to be followed by a treatment-free remission. The combination of lenalidomide and rituximab was studied in CLL even before it was studied in other lymphomas where it's had more traction. Dr. Farajoli and her colleagues at MD Anderson and also Dr. Donnell James and our group at UCSD and the CLL Research Consortium studied this combination as both treatment for patients with relapsed disease or also even for frontline treatment. We did observe excellent efficacy and high response rates, and kind of anecdotally, I still have patients that are continuing on lenalidomide several years later. There are some unique features of lenalidomide, including a risk of tumor flare reaction, a risk of thrombosis that I think requires some attention from the treating physician. But I think it is important to remember that it is also an option. I think the access to lenalidomide now, at least in the States, to treat patients with CLL is a little bit more difficult, particularly with the development of other agents. I think for patients who maybe don't have other options, it is a consideration.